We're just here to discuss, essentially joining a few concepts that we've put forward. So one of the early concepts that I put forward in an older video was the concept of relational motion. One thing stays still, one thing moves in relation to it, or both things move in relation to one another in a slightly less controlled, kind of more confusing way as far as your ability to manage the outcome that you're looking for. So we've got relational motion. One thing stays still, one thing moves in relation to it. We've got the barrier concept, right? So direct, as far as using the direct barrier or going into the direct barrier, the experience the practitioner will have is that the tissue will get tight, right? Usually when you go into the direct barrier, it's because upon engaging the direct barrier, going to the direction of bind, the direction of resistance, there is no pain, right? So the patient doesn't say ouch, the patient doesn't wince, pull away. The indirect barrier is essentially, the experience for the practitioner is that the tissues will go soft, right? So that's the primary thing, as tissues go soft. The reason usually you go there is that when you will engage the direct barrier, the patient will wince or pull away or say ouch. Then we also have the concept of activating forces, so compression, distraction, torsion, and shear. So we start to put all those together. When you're watching osteopathic treatment or when you're watching hands-on manual therapeutic treatment, one of the problems is it's kind of hard to see some of the things that are going on, because if you don't know what you're looking at, obviously you won't be able to identify it. Also, most practitioners are not organized in their approach. They will, in description, say that they go by feel. My hope, my suggestion, my aim is to create some form of lexicon, some form of discussion around being more organized in your approach, right? So if we take something as common as a leg rotation, right? In this case, we would have already assessed, or in any case, you've already assessed, you've found some reason to create hip flexion with hip rotation, or maybe attempting to create some form of motion in the lumbar column. So your leverage, your long leverage, happens to be the patient's thigh, and in this case we'll say that we're working in the lumbar column, right? So from this hold, right, what I'm going to do is we're going to say that I've chosen, because there's no wincing, no pain, that I'm going to choose to go direct. I'm going to choose to attempt to induce lumbar flexion, right? So essentially opening of the backside of the lumbar, or forward bending. One of the reasons we can talk about forward bending is because the patient's torso and thigh are approximating one another. So that would be also another place to look for lumbar flexion, when the torso and the thigh begin to approximate, begin to come closer. So we're going into the direct barrier. What I'm going to do, so the relational motion, essentially what happens is my hand stays still and the patient's pelvis doesn't necessarily stay still, but the rest of the spine or the rest of the vertebral column above where I'm working is going to relatively stay still. One of the ways that I manage that is with my palpatory hand under the patient. I can feel where the motion stops. If I feel motion go beyond my hand, then the thing that I'm not trying to move is now moving. So the thing that I'm trying to keep staying still is not staying still. What we do is we bring that leg up, we create the leverage, the long leverage, we create the motion to begin to induce lumbar flexion. So we've got a relational motion component, and we're monitoring that with the palpatory hand. We've got the fact that we're going to the direct barrier. Now we've got our activating forces. With this hold, there are certain things that are hard for me, right? Compression is fairly easy, so because I'm going direct, I essentially want to develop more tension. Now in this case, I lose tension on those soft tissues, on the tissues that I'm monitoring in and around the bones that I'm trying to move. So compression does not do what I want to do. Distraction, now the thing that you won't be able to see here is, as far as the distraction is concerned, because I'm wrapping around essentially the shin and the thigh, if I'm here, right, I'll have a hard time. If I wrap my hand around the patient's thigh, right, and in this case, something that you probably won't see, but something that I'll often talk about or often try to teach people about, is sometimes kind of grabbing your own clothing in some way helps to shore up your grip. You have something else to grip on that you won't slip on, right? So I wrap around, I've got contact. I can create the distraction of the lever, right? I can gain more tension, then I can use torsion, right? And shear isn't really available to me here. So what I've done is I recognize that the distraction and some torsion helps me gain more tension. Now, as far as patient activating force, I can start to add in other layers. So it starts to get sometimes extra complicated for no good reason. But here what I can do is I can have the patient push their left leg down on the table, and that creates more tension. So when you let it go, I lost some of the tension, which is fine. I can compare that against push your left shoulder down on the table, and that does something that I like, and let go. Creates more tension. Push your right shoulder down. That creates even more tension. So what I'm going to do in the relational motion thing, now what I'm going to do is I built as much as I can passively off my lever. I'm going to have you push your left leg down, your right shoulder down, and I build a lot of tension and let that go. So now what we've done is we've had patient passive in the way that I control the lever, built as much tension as we can. In this case, it was with some distraction and with minor torsion of the lever, leading to more tension in the region that I was palpating in a lumbar column that I want to work on. Then what we actively did in a purposeful sense, we had the patient push varying kind of portions of themselves into the table, so that when the lever and the anatomy that I'm working on relatively stay still, the patient actively moves other portions of themselves. And what we did is we compared that. So we had the patient push this leg, the left leg, and the right shoulder, and that gave us a lot more tension. So a method like that, although it looks just directly like a leg rotation, what we really have is we have the selection of barrier, we have relational motion on all levels in all of these things, right? That permeates the whole deal. Then we have passive, using the lever passively with activating force, and comparing them, going through all of them on purpose to see what gives us what we need. Compression, distraction, torsion, and shear. We got something off of distraction and some torsion. Then we had the patient actively go through it and activate. And the way that the patient's activation happens or is useful to us is because the thing that we're working on stays relatively still, and the patient moves themselves in relation to that. So again, it's another utilization of relational motion in action. So these all start to blend together. You can pick and choose which ones of these approaches that you want to use as far as activation is concerned. The whole aim, again, here is to provide you the impetus, provide you the drive to be more orderly about it, to control what you're doing so that you can then control your outcomes. You have a better understanding of what you did.